All right, so in this talk, I'm going to cover implementing high-intensity gait training as standard of care during inpatient stroke rehabilitation, specifically in the first Indiana project. And I'll talk briefly about some of the work that led up to this in other sites. So some background before we get going. As you are likely aware, stroke is a common condition and a common neurologic diagnosis that we see in physical therapy. The care associated with this diagnosis is expensive, and walking is frequently affected in these individuals, which is why we end up seeing a lot of them in physical therapy. Conventional strategies that we have in our toolbox to improve walking function after stroke include incrementally challenging the patients. So really doing a little bit more than they can do in that particular moment, really not trying to have more than kind of minor errors to what they're doing, and kind of incrementally progressing what they can do in that manner. Conventional therapy also distributes practice across the different deficits. So although walking is frequently affected, many aspects of functional mobility are generally affected after the stroke. As a result of that, the therapy interventions and what we do during physical therapy is frequently distributed across a range of different functional mobility deficits as well as impairments that begin following the stroke. So this pie chart here is actually from the first Indiana data set, but similar ones have been published previously. And really what it's looking at is the amount of time during a therapy session and what the therapy sessions are working on. So while walking is a large piece of the pie, there are many other pieces of the pie that occupy time and effort during a typical therapy session. Conventionally, we also think of a hierarchy of interventions, which essentially means that if you think of someone that's really impaired after a stroke and maybe has impaired capacity to even sit, you're really, as a therapist, really going to work on getting them to master their ability to sit before maybe you try working on sit to stand, before maybe doing some standing type things, and then some dynamic weight shifting before ultimately getting to walking, if you don't get hung up somewhere along kind of that progression. So for some of these people that start with the inability to sit, it takes a while to, if you're even able to get to it, to get all the way to practicing walking, which is also going to limit the amount of practice that you can get. And like I alluded to with the pie chart and this hierarchy interventions, in typical conventional therapy, not a lot of walking practice is actually provided. Observational studies generally see somewhere between around 250 to 300 steps taken in a typical therapy session, which is much less than the anywhere between 2,500 to 4,000 steps that are feasible in some of the research studies that really focus on trying to maximize the amount of walking practice. Furthermore, beyond what just is being done in terms of the types of interventions that are being provided, the interventions that are being provided, regardless of whether they're walking or otherwise, are generally of very low cardiovascular intensity. So work from almost 20 years ago at this point suggested that only about 5% of a typical physical therapy session is of aerobic intensity. And other work by those investigators identified that when nursing gets the patients dressed in the morning, they typically have higher heart rates than they do during physical therapy. So cardiovascular intensity not generally targeted in physical therapy. As I mentioned, the first Indiana project that we're going to focus on was predated by a few different studies. The first of those is known as FIRST, so FIRST is an acronym for Focused Intensive Repeated Stepping Training. This project occurred in Chicago, so it's affectionately known as FIRST Chicago. Published in 2015 with the data being collected in the few years prior to that. Really looking at knowing what conventional therapy is and what some of the emerging evidence suggests, where the amount of practice that we can provide, the cardiovascular intensity being important, the practicing in different training environments, targeting the biomechanical deficits, and explicitly inducing errors. We have all this data to suggest that these things may be beneficial, but since they're not done in routine clinical practice, can we actually make this happen in routine clinical practice? And more specifically, can we do this during inpatient post-stroke rehabilitation? So to look at whether it was feasible to make this happen, there were 2 floors of a single rehabilitation hospital in Chicago. And over the course of 16 months, they tried to do just that. So for these 201 people that consented for their data to be used in this study, just trying to maximize the amount, intensity of walking practice, along with those other things I mentioned. There was not a regimented protocol like there is with a typical research study. It was really left to the treating therapist for how to go about applying that program to their patients. In terms of what they found in this study, they found that the individuals were able to get heart rates across the different sessions. So peak session heart rate max was 70% of age predicted max. And of the sessions that had documentation of RPEs, 38% of the time across the sessions, the RPEs were at least a 14, meaning that they were harder. They were between somewhat hard and hard at a minimum. The median steps per day were about 1,500. So if you remember what I mentioned before, previous studies of conventional therapy identified about 250 to 300 steps in a typical session. So this is 5 to 6 times the amount of practice being provided, in addition to, again, remembering that about 5% of a typical therapy session is at a aerobic intensity. Importantly, when they compared the frequency of adverse events in the individuals that participated in this study to published information about the frequency of adverse events, there was no difference in that. So again, when we do anything that with our patients, we want to be mindful of both the potential benefits and the potential risks. So the fact that there's not an increase in adverse events is important when considering changing our practice patterns. In terms of the positives of this particular program, they identified that the amount of practice that the individuals get, which is shown here across the bottom, and looking at what the individual's discharge 6-minute walk test was, so walking function at discharge, they found there was a strong, positive, statistically significant correlation between those two, meaning that you have a dose-response relationship between how much practice they get during therapy and how good they are at walking when they leave therapy. So one of the things that you might wonder about is if patients, this is great, but patients might get more practice just because they're higher functioning at the start. So could it be just that you're getting more steps with people that are higher functioning, and there are those cluster of red, orange, and even yellow dots at the bottom that really aren't getting much practice and aren't getting much better? The rebuttal to that critique is looking at a similar figure that compares the amount of practice to actually the change in the 6-minute walk test. So you can see that the amount of change is still small in individuals that were total assist to mod assist at discharge. But now when you're looking at the amount of change that they get over inpatient rehab, you still have that positive, significant relationship. So it's not just the higher functioning people at start, it's how much practice you're doing is related to how much better you get at walking by the time you leave. So take-homes from this study, really emphasizing the fact that it's feasible to increase the amount and intensity of walking practice provided during inpatient rehab, and it's safe, right? So you didn't have that difference in frequency of adverse events when compared to usual care. Participating in greater amounts of walking practice was associated with a lot of good things. So I showed just the data for the 6-minute walk test. There was similar data for changes in Berg score. The amount of walking practice predicted the amount of physical assistance necessary to walk at discharge. And we know that patients frequently have goals to be able to walk better by the time they leave. And so somewhat not surprisingly, walking function is an important predictor of where the individual discharges after inpatient rehab. And having more walking practice was a predictor of getting patients home as opposed to some other level of care. So a whole variety of different things positively associated with getting more walking practice in during inpatient rehab. The major limitation to this study is that there wasn't a usual care group to compare this to. So it's great to look at how this single group of individuals behaved. However, we don't know if the outcomes are specifically different from what might have been gotten during usual physical therapy. So that being really the primary critique. The next project to talk about briefly is the first Oslo project, which really tried to address that major shortcoming of first Chicago. So Oslo being a city in Norway, two rehab hospitals in particular in Oslo, Norway, participated in this project. And this project really started when the treating physical therapists at these facilities learned about the high-intensity stepping protocol, collectively reviewed the different studies over the course of at least a year or two, and decided together that they wanted to implement this as their standard of care at their facilities. So they actually planned ahead of time that on a particular date they were going to switch their practice to this other thing, and really try to understand whether or not that made a difference in terms of outcomes. So for this study, there was 10 months of usual care, where 56 people had their data collected, observing kind of what happens with usual care physical therapy and the outcomes that are able to be achieved. That was followed immediately by 10 months of implementing the high-intensity training with a similar number of patients. When we look at the results of this study, a few things that really kind of jump out. One, comparing the two phases, there were significantly greater amounts of steps per day and also steps per PT session. And when the individual was stepping, they were stepping at a greater rate. So all things indicating that more walking practice was being provided for the patients in the high-intensity training phase. So increasing the amount of practice. In terms of the intensity of the interventions and the sessions, there is not heart rate data available for usual care. This was an intentional decision by the clinicians because monitoring heart rate during usual care physical therapy was not something they did, and they didn't want to add heart rate monitors to that out of concern that that would alter their usual care practices. So that's why that data aren't available. But looking at the data that are available for the high-intensity training phase, you can see that the peak heart rate achieved during the session was about 80%, which is right in line with what was achieved in the first Chicago study. The time in the heart rate range was about 34% of the session, which is not totally different from the 38% of the session in first Chicago that were in the RPE range. One of the things, just as kind of an aside to know, is that in Norway they're much less likely to prescribe beta blockers. So whereas in first Chicago and then later on in first Indiana, beta blockers frequently limit the utility of heart rate and looking at time in the zone and peak heart rates and whatnot, that using the RPE scale is generally really valuable for these significantly impaired individuals after stroke that, in addition to the beta blockers, are going to have limited capacity to activate their neuromuscular system and then subsequently drive the cardiovascular system to get the higher heart rates anyway. Similar to first Chicago, now actually comparing between usual care and HIT, there was no difference in the frequency of adverse events with the provision of the high-intensity training. So looking at the outcomes for this study, the black lines represent the post-implementation or high-intensity training group. The gray lines represent usual care. The outcomes that were focused on here were self-selected and fast gait speed, 6-minute walk test, and the Berg balance scale. So 3 walking outcomes and 1 non-walking outcome. Across all 4 of these outcomes, individuals in the HIT phase had significantly greater gains than compared to usual care. One of the things that's also sort of highlighted here is that the black lines go on further than the gray lines. So one of the other pieces that come out of this was that the length of stay was significantly longer in the HIT phase by about 12 days, which is about 50% longer. And really, in speaking with the clinicians, the idea was that they were seeing such greater gains in their patients that they wanted to keep their patients longer. And I mentioned there were 2 hospitals involved. They're technically different levels of care in Norway, and the patients would frequently spend some time at one and then transition to the other. So you do have differences in lengths of stay in this study. However, if you focus on really like an apples to apples comparison of looking at changes after 1 week or 3 weeks, For the walking outcomes in particular, you have significantly greater gains at all of those time points for the implementation group. The Berg group was not different, which I think is, for one, can be thought of as kind of a negative. But when you think about what usual care is compared to the high intensity training, usual care frequently involves practice of static balance tasks. That was a piece of the pie chart that I showed early on. If you're doing more walking practice, there's theoretically going to be less time to practice static balance. So you're getting these greater gains at walking, which you would hope you get with more focus on walking, but also really encouraging that there's not this explicit trade-off that's being made, right? Usual care for the Berg scores are not better than a HIT phase, because then you would have to make kind of decisions as a clinician about what's best for your patient. The last piece of data to look at with this study are the outcomes at admission for both phases of the project. So again, in Norway, which is going to be different than the United States, these patients are much higher functioning. So if you look at just self-selected speed as an example, it was around 0.6 for both the usual care and high intensity training phases. Berg scores were about 35, 33, so in the mid 30s. These are scores for individuals that in the United States might be getting admitted, starting their outpatient therapy or even getting discharged from outpatient therapy. So much higher functioning than in First Chicago, the median Berg score was a 5 at admission, and I think gait speed was a 0. So these are really impaired people that are typically presenting to acute inpatient rehab in the United States, whereas the individuals admitted in Norway are seemingly a different level of function in a different population. So in terms of take-home messages from this particular project, as I mentioned, we have greater gains in walking function with the participation in the high-intensity gait training. So practicing walking gets you more better at walking. And then for the Berg scores, there doesn't seem to be a trade-off, right? So you do have the longer length of stay to keep in mind, but Berg gains were significantly better with participation in HIT. So you're not really making a trade-off when these patients have goals other than improving just walking, which is also really encouraging. There was no increase in adverse events. And then the primary limitation to this study in terms of potentially looking at it for inpatient rehab in the United States is that these patients may not be of a similar functional level to what we're used to seeing. So that brings us to First Indiana and the Rehabilitation Hospital of Indiana in particular. It is a 64-bed acute inpatient rehab facility. Stroke accounts for 30% of the individuals admitted to this hospital, resulting in about 300 admissions per year for individuals post-stroke. The story for implementing here really starts with leadership at the hospital being specifically motivated to try to identify strategies to improve patient outcomes. And the two that they really settled on were increasing an emphasis on evidence-based practice by their clinicians and increasing participation in research as a facility. So this is one of the 2 therapy gyms at the Rehabilitation Hospital of Indiana. And these 4 little windows here are where the locomotor recovery lab that George Hornby directs and I work in physically sits. So a really nice setup in terms of having research and clinical practice as close as possible together, which really should lend itself to helping research drive clinical practice, so really helping facilitate the clinicians provide evidence-based practice, and then hopefully also having clinicians drive research questions in terms of what they're seeing clinically when they're putting the latest evidence into clinical practice. So really, hopefully, a good symbiotic type relationship between the two. But that's us behind the windows there. So the original plan was this project was prior to actually starting the implementation or even the usual care, we wanted to implement standardized outcome measures as well as make sure all the therapists were trained on how to use the heart rate monitors, treadmills, whatever other sort of equipment was available that they might be able to use to provide high intensity gait training. And the reason we did that was we didn't want the equipment or training related to the equipment to be part of what we were implementing. That was something that we wanted to be separate. So after we did that, the idea was we were going to monitor usual care. In this case, the plan was to monitor for 12 months. And then over the next 24 months, we were going to implement high-intensity gait training was the plan. It didn't actually turn out like that. We did okay with implementing our outcome measures and high-intensity gait training equipment. But as you may remember, we are sitting there watching therapy, and it's really hard for us to do that instead of getting in there and trying to implement the evidence-based practice. We also have leadership frequently kind of wandering into the lab saying, hey, how long do we need to wait? Do we really still need to wait? Can we get going? So we actually only made it 9 months before, instead of the 12, before we went forward and started to implement. What we didn't necessarily expect was how hard it was going to be to change practice, and we'll talk more about that in a little bit. But it took about 18 months to make enough change in practice to the point that the fidelity metrics were such that we felt like we could potentially say we had implemented and start to evaluate whether the changed practice patterns actually made a difference for patient outcomes. So we have about 12 months of implementation phase, or phase 3, before the COVID pandemic shut down all research activities and then therefore ended this project. So we weren't necessarily planning on wrapping up the project at month 39, but the pandemic had other plans. All right, so in terms of the outcome measures and the HIT equipment, for the outcome measures, we plan to assess them at admission, weekly, and discharge. We focused on 3 in this outcome measures battery. The first being the 10-meter walk test with the directions to walk at your regular, comfortable pace. Physical assistance was provided as needed according to the FIM scoring for the FIM walk. So total assist all the way to, say, contact guard and beyond, but without the distance requirement. So that physical assistance was allowed for stance stability and postural stability, but not limb advancement or propulsion. So helping keep the patient upright, but not advancing forward. Similarly, the 6-minute walk test also allowed for physical assistance as needed with the same scoring, but the directions for this assessment were to cover as much ground as possible. The final item was the Berg, which we had standardized scoring for each of the individual items. And we helped develop this standardized administration with an existing outcome measures committee at the Rehab Hospital of Indiana. We helped make sure their equipment was available. So at the top, you can see some of the items you might use for the Berg. At the bottom, you have lines to do an FGA, but there are also little, you may be able to see right next to the parallel bars, there are little small rectangles of tape which are marking off 2-meter increments for the 10-meter walk test. We also tried to help reinforce not only that collecting the outcomes was beneficial for the research itself, but educating the clinicians on how they might use the outcome measures for prognosis and clinical decision-making regarding the patients themselves. So providing different tools. These are kind of the portable laptop stands where the therapists do their documenting, and you see this card kind of attached to it. That has information on different outcomes in the core set, in particular, psychometrics, MDCs, MCIDs, cutoffs, those sorts of things that you may want to use for goals. And then we also made kind of a similar type card specifically geared towards the non-therapist team, part of the interdisciplinary team. So providing things like you can kind of see here with the ranges of scores on, say, a Berg, and globally what that means in terms of their function. So that way, say the supervising physician or the OT or whomever, when the therapist might report that the patient has a Berg score of 4, the rest of the team has an idea of what that means. And the idea in part was by helping educate the rest of the team, that would hopefully get buy-in with the team and help reinforce the collection of the outcome measures. One of the other things we were able to do was include the treating clinicians as blinded raters for some of our other research studies. And that really gave a good opportunity to help standardize the outcomes assessments, because it gave us as the research staff a non-threatening way to provide constructive feedback to the clinicians about the standardization techniques for the outcome measures. And in terms of feedback that we provided regarding the collection of outcomes, it was only informal, which differs from some of the feedback we provide later on. But really, feedback was primarily consisting of us potentially identifying that a week of rehab for a particular patient might be nearing an end. Maybe there were a few different therapists treating the patient that week, and outcomes, didn't get collected for whatever reason. We might give a heads up to the therapist treating the patient the next day to hopefully encourage them to collect the outcomes. In terms of how we did actually at collecting outcomes, this focuses only on outcomes collected at admit and discharge, because those are the only ones we're going to talk about when we actually evaluate outcomes for this study. Across the bottom, you have different quarters or 3-month periods of the project, and then looking, just kind of tracking the compliance across the project. So in usual care, we were at 79%. That continued to bump up over the course of the project, and we were at 89% overall for the entire project. There were likely some factors influencing success with this. We did work with the existing team, so we engaged the relevant stakeholders, and we also work to engage the rest of the interdisciplinary team to help get buy-in from them. In terms of things that might have limited our success, we only provided the informal feedback, and globally we had a difficult time getting buy-in to collect outcomes on really impaired patients. So, say for patients that had lacked the capacity to sit independently, total assist for transfers, those sorts of patients, it was difficult early on to convince clinicians to do walking-based outcomes because their patients can't sit, so why would they walk? Which is reasonable. The problem is that, one, it's very easy to assess outcomes for those patients, right? So you documenting that, a lot of education about the importance of getting that initial score, even if it's a 0, so that you can potentially demonstrate change as your patients hopefully changing in terms of function over the course of their admission. And even the Berg, which, if the patient has some capacity to sit or some capacity to transfer, we'll get some score on it. I think the concern with the Berg was that these really impaired people wouldn't be able to show objective change in that outcome. So again, providing lots of training and actually sharing some of the data that are out there, indicating that that's really not the case. All right, in phase 1, we wanted to monitor usual care. In order to do that, we put the stopwatch on all the patients throughout their therapy day to track the amount of walking practice they were getting, both in physical therapy and as well as with the rest of their day. And we didn't give any guidance on what the therapist did. We just wanted to monitor what care was typically being provided. So this pie chart here comes from observing a little more than 60 therapy sessions during usual care and looking at the amount of time spent practicing different therapy interventions. So as alluded to earlier, there are many different pieces to this pie. Walking is a very large piece amongst the others, but still doesn't make up even half of the time spent during a therapy session. But keeping in mind that this pie is really similar to what happens kind of throughout conventional rehab and is not unique to this facility. In phases 2 and 3, we worked to implement high-intensity gait training. Specifically, we wanted to implement it as the primary physical therapy intervention. It's important to note that no additional personnel, equipment, or therapy time was provided. So it was really, the idea was that it was the same as in usual care, except we were providing training to the therapist about using their time differently, potentially. So there weren't more aids, they didn't get new treadmills or other sorts of harnessing type systems. The patients didn't get an extra 30 minutes of therapy to do this. The idea was that this was something different that the therapists were doing with the time that they had with their patients anyway. The other thing to note is that of the 525 individuals that were in the transition and high intensity training phases, 500 or 95% were cleared by the supervising physician for high intensity gait training. The remaining 5% were only cleared for moderate intensity training, which is going to be 65 to 75% of age predicted max and RPEs of 11 to 13. Those 25 individuals were included in the analysis. So it's everybody that's included, regardless of what they were cleared for. So we likely had a number of things going for us in terms of helping us potentially implement. We touched on leadership sort at the beginning. Leadership was very much on board with trying to implement an evidence-based practice. We have motivated patients. So this practice in particular that we're trying to implement hopefully will improve walking function. And as I alluded to from the first Chicago data, walking function is going to be, one, an important goal for patients in general, but an important predictor of getting home. And everybody wants to go home. So it works really nice in this case that what we're trying to implement is related to what the patient's goals are. And the third thing to highlight is really having the research staff on site. So whether it was for mentoring in the moment with a complex patient or troubleshooting some equipment that might not be working, it seemed to be really beneficial to be able to quickly address barriers as they came up rather than having some delay and potentially losing some momentum. In terms of barriers that we had to work through, we had to work through the current PT practice and beliefs. And in particular, thinking about this pie chart. So we showed the compliance or success with collecting outcome measures. And as we've talked about in other talks, implementing outcome measures is not necessarily the same thing as implementing high intensity gait training. And I think one of the major reasons for that is that, one, clinicians are generally on board with the concept of outcome measures. That's been something that we've talked about as a profession for a lot longer, which helps. And also, really, I think the important fact is we're talking about adding it to their toolbox. So we're not asking them to really change much with their practice. We're just asking them to add one more thing to it, which is really different than the high intensity gait training, where we're not asking them just to add high intensity gait training to their toolbox of interventions. We're really trying to get them to remove the other tools in their toolbox and really prioritize the high intensity gait training. So that can be a much harder sell to really de-implement existing practice. So that definitely being a thing we needed to work through. Patient and caregiver preferences. Being sedentary and having a lower level of physical activity is a really big risk factor for having a stroke. So for the patients that we're seeing after stroke, exercise in general may not be something that they're used to doing or enjoy doing. They may not necessarily enjoy sweating. Their spouse may not enjoy watching them sweat or be really tired or fatigued or whatnot. So the high intensity training may not be their preferred way to exercise in therapy. And then finally, organizational processes. So a number of different kind of issues that we kind of had to work through, but one of the ones that comes to mind is I showed that picture of the therapy gym, or half of the therapy gym, and pretty quickly early on in this project, we started spending a lot of time walking in the hallways because you need some space to walk to practice walking beyond just the treadmill. And that wasn't necessarily well received. There was a lot of kind of confusion about why, if therapy has these large gyms, why do they need to kind of push out into these other spaces? Can't they kind of just stay in their lane and we'll kind of stay in ours? So that was really a process that we kind of had to work through. In terms of what we did specifically to try to overcome these barriers, I mentioned de-implementation, so a lot of training not only for the therapist but for the aides, so that the aides could be as helpful as possible with providing the intervention. We did a lot of mentoring. So, like I mentioned, whether it was a planned mentoring of, hey, like I'm working with this patient, I'm having a difficult time, tomorrow, can we try to, I see them at 9 o'clock, can we schedule some time to do that, versus, hey, I have them in the harness right now, it's a mess, like, can someone come out and help? But really a lot to help with problem solving for specific patients. One of the other things we did to help with communication and getting this going quicker, we worked with the IT department to create an order set in the electronic medical records for high intensity training. So when the physician, when we first started, the physician would put in with the rest of their orders an order for high intensity gait training. After a few months, with the physicians realizing they were clearing the vast majority of patients, and sometimes forgetting to click that button to add that order, resulting in some confusion, they switched to the opposite of, rather than ruling in hit, they were ruling out hit. So the idea was that unless there was an order set specifically for moderate intensity training, the expectation from the physician was that the therapists were doing the high intensity gait training. And the final thing mentioning here is a lot of audit and feedback. So really auditing a couple different things. One being, I showed you the stepwatch or pedometer we used. So looking at the amount of practice patients are getting. So this particular example here is for a single patient. So you have dates across the bottom. So this is about a week of therapy. There's going to be a bar every day that we have data from the stepwatch. And then you have a couple lines here. So if outcome measures were collected, you might have a dashed line, which indicates individuals that require a similar amount of physical assistance to walk. From the first Chicago data, we're able to get this amount of steps. And then with the solid line, that was based on the patient's Berg score. So not only did you get feedback on whether or not the patient was wearing the stepwatch, you got feedback on how much practice they were getting and how that compared to other individuals of similar levels of function. That feedback was eventually provided, rather than being at the patient level, was provided at the therapist level. So here you see PT1, PT2, PT3, et cetera, et cetera. In the actual feedback sheets that has the therapist's name, and everyone on the team knew everyone else's kind of performance with this. For PT1, as an example, you have 4 different rows here. Each of those rows represents a 3-month period, so a quarter of the year. So this 431 might be the most recent quarter, and then the preceding quarter, working their way up. And the idea being with that, you could look at kind of performance over time. So hopefully you see that number going up over time. And then you have 3 columns based to stratify the level of impairment of the patients. So as you might imagine, individuals that require max or total assist to walk, you're probably getting less practice in than individuals that are contact guard. So again, providing benchmark data from First Chicago to help with kind of goal setting or benchmarking. So you have that kind of external reference, but also the idea being that if you identify maybe that you're really good at getting a lot of practice for your max total assist patients, but not getting nearly as much practice with your contact guard, one, identifying which group, maybe an area of improvement or growth. But also maybe you see another therapist, maybe therapist 3 does a better job with that particular group. So maybe you seek out some feedback from them on some strategies that they have that work. Beyond just the stepwatch, we also audited therapy documentation to look at walking practice, cardiovascular intensity, et cetera, and provided similar sorts of feedback regarding what was actually being done in the therapy sessions. The next barrier for the patient and caregiver preferences, we definitely provided a lot of education, a lot on the dose-response relationship. So, we're focusing on walking because the more walking practice we get, the better at walking they get, et cetera, really emphasizing the findings from the first Chicago study. Differentiating performance from retention. So The idea being it doesn't matter what they look like. So if they have concerns about the sweating, the fatigue, the not normal movement patterns during therapy, really focusing on what they look like before and after kind of the course of their plan of care as opposed to during it. And then another important finding from First Chicago, where gait is a primary predictor of discharge location. So similar to the patient, the caregivers, wants the patient to get home a lot of times as well. So really emphasizing that as an important part of why we're doing what we're doing in therapy. That feedback that I mentioned, that was provided to the therapist, was also provided to the patients in cases where that was appropriate. So you might see therapists choose to give it to certain patients that they felt like maybe were being tough on themselves, and maybe were getting a lot of practice compared to what their outcome measures said they might be able to do, but were really focused on kind of their prior level of function, or conversely, maybe someone that they were having a difficult time getting buy-in to do more because the patient felt like they were working hard and maybe they weren't necessarily. So it was really left to the discretion of the supervising clinician who to provide this feedback to, but that was an option for them. And then finally, for organizational processes, to get buy-in from the rest of the team, we did a lot of education beyond just the PTs and the aides to make sure they understood what we were doing, why we were trying to do it, et cetera, et cetera. There were concerns about the effect of doing high-intensity gait training on the other therapy disciplines. So specifically, occupational therapy had concerns that when these patients do the high-intensity gait training, they kind of get ramped up in terms of a spasticity point. And that made it difficult for them to do some of the upper extremity tasks that they needed to do. So to do that, really working with scheduling to avoid scheduling OT immediately after PT. Conversely, some of the speech therapists really felt like that for certain patients that maybe had a difficult time engaging in the speech therapy cognitive activities, that doing that immediately after an aerobic exercise session was really beneficial for that. So there were certain instances where speech therapy specifically tried to schedule their sessions right after physical therapy. And then really thinking about all these together, I think one of the things that was really beneficial for all of them was having some early examples of success. And what I mean by that is not a single session, not where a therapist and a patient work together and have a quote unquote good session of high intensity training in terms of it being efficient and getting a lot of practice in and whatnot. But really patients that have really good clinical outcomes in terms of kind of where you might expect them to kind of discharge. So whether you're thinking about the therapist specifically or anyone else on the therapy team that works with these individuals, I think they over time with their experiences kind of identify kind of what their prognosis is for patients by the time they leave the facility. So like if someone comes in as a max total assist to sit, generally they're leaving at a wheelchair level, say, as an example. So when you're able to have some of those successful examples where you have those really impaired patients that walk out the door or walk back in the door when they come for outpatient therapy or whatnot, that really makes a difference for getting buy-in from the team. Some of these patients that did the high intensity training, and whether you're coming back for outpatient and really being encouraging to the inpatients and their family really helped with buy-in. But in general, in a number of different ways, these successful patients really kind of had a positive kind of spiraling effect on the implementation efforts. So in terms of actually measuring our ability to implement, we had to define what fidelity of the intervention was. Our primary fidelity metric was prioritizing walking, in particular trying to do so in 80% of sessions. So when we think about the research studies themselves, they only practice walking, so they're doing it in 100% of sessions. We recognize that's not going to be feasible. One, in part because there are other things during inpatient rehab that just have to happen. So, for instance, family training has to happen. There are going to be times that you have orthotics consults or wheelchair consults, or maybe pain derails a session or toileting derails a session. So going through, removing those sessions from this analysis, but really trying to get at the point that we are prioritizing walking in most of the sessions was the idea. So really taking that pie chart at the bottom left, where other stuff makes up the majority of time, and really shoving it to as small of a piece of the other stuff as we can. Our secondary metric was related to the intensity interventions. And as I talked about before, with the level of neuromuscular deficits typical of patients that come to inpatient rehab and the high rate of beta blockers, we didn't know what was actually feasible in terms of heart rates and RPEs that we could get in this set of individuals. So we didn't actually set a goal for the amount of time in the heart rate zone or achieving the target heart rate. Rather, we focused on just whether or not the clinician was documenting it, and hoping that meant that they were trying to increase it. Really is where that ended up kind of going. Okay, so looking at what actually occurred during therapy, and this is based off of the audits of the therapy documentation. So what happened with this was that I would look at all the interventions that are provided in a single session and essentially give them yes or no answers to a number of different questions. And a couple are here and a couple are on the next slide. So looking at the interventions that were provided, was the task of walking practiced at all? So was even a single step taken during the session? So yes or no for that session. And looking across, I think there ended up being about 12,000 therapy sessions across this entire project. The other question for walking was walking practice prioritized? So again, in a given session, you might have outcome measures done, plus, say, walking practice provided. So in that case, the idea would be that you had to do outcome measures, but you then, amongst the time that you had in your session to pick some sort of therapeutic intervention, you picked to practice walking. So you prioritized walking. So even if there were other things that had to happen, maybe you did some walking and then you had to spend half of your session doing toileting type things, that was still prioritizing walking. So individual sessions were scored as either having prioritized walking or not having prioritized walking. Throwing the 80% kind of target that we have for our primary fidelity metric on there, because that's how we're going to look at that. And then tracking it over the project. So you first have the diamond that represents usual care. That's followed by the different quarters of the project where we attempted to implement. And these are the metrics that we really kind of watched as we went to look at whether or not we were making, one, were we successfully performing the intervention, and two, if we weren't, were we headed in the direction that we wanted to be. So you see a bump right after we started to implement. So right after the initial kind of training was provided to get the clinicians to try to change their practice, you see a bump, and then kind of a slow, gradual climb after that. I do think over the last 4 quarters, you see a kind of a second bump, and we'll talk about that in a second. But keeping that in mind as you look at these next two. So one, looking at whether or not the cardiovascular intensity of the sessions was documented. So that's going to be that's not going to include if the therapist took heart rate and blood pressure at the beginning of the session. That's not going to include something where it indicates that the patient was walking and then felt dizzy and the therapist sat them down and then took vitals. It's got to be something to indicate that the heart rate or something about the intensity intervention was being assessed to specifically guide clinical decision-making to, say, titrate up or titrate down, if that makes sense. So in the moment as opposed to reactive. And then whether or not the target aerobic intensity was achieved. And that could be either heart rate or RPE, so achieving at least 75% of age predicted max or achieving at least an RPE of 15 on that 6 to 20 scale. And if intensity was not documented, we assumed that the target intensity was not achieved. So the idea being that if you didn't document intensity, you probably weren't monitoring it and focusing on it. But as you guys are likely aware from the Woodward 2019 paper, just doing a 6-minute walk test in someone post-stroke, about half of them get to the high intensity range. So it's probably conservative to say that the high intensity range was never achieved, but that's what we went with these. So cardiovascular intensity was only documented about 1% of sessions. Again, you see that bump immediately with the initial training that continued a kind of a slow climb, and then similarly on the right as well. And again, you see over the last 4 quarters a bump compared to where they were before. So that's where we're going to draw the line to separate the transition phase and the high intensity training phase. We do think a couple things contributed to that bump. One, there was a change in therapy leadership right around that time. And with that change in therapy leadership, one of the things that they really emphasized was that evidence-based practices and doing them was not just something that they were going to talk about as a hospital. It was something that they were going to use as a practice expectation, and that the high-intensity gait training was a practice expectation for the clinicians. The other thing going on at that time is that's when we switched from the patient-centered feedback, which were those bar graphs with the stepping activity, to the therapist-specific feedback. And I think the way I think about that is that when you're thinking about a patient during inpatient rehab, a lot of times there's a few different therapists that work with them. Maybe sometimes they have multiple sessions per day. Those sessions might be with different therapists. So when you see that feedback as a clinician, it might be hard for you to remember which, did I see them Tuesday or Wednesday? Or maybe you saw them when there was another therapist seeing them that day, and you see that your bar is a little bit lower. But the idea is, maybe it must have been the other person, because I know I did what I was supposed to. And I think it's really similar to when, I took a test in school, and before the teacher handed back the exam, she would talk about what the class average was. And globally, these were the strengths and weaknesses of the class. And it was easy for me to sit back there and think that, well, I'm better than average. This doesn't really apply to me or whatnot. And you didn't really know until you actually got individual your score back on the test, the individual feedback to really let you know whether or not you were kind of hitting the mark. And I think that was kind of what ended up happening here as well. All right, so this is the flow chart for our study. So over the course of the project, there were 958 individuals that were admitted post-stroke to the facility. There were 134 that were excluded because they did not meet the inclusion criteria. The inclusion criteria are here. So you have to be recently after your stroke. You have to be an adult that's not too old, and that's an IRB requirement because you're no longer anonymous once you get to be past 89. You couldn't have any weight-bearing restrictions, so you had to have the capacity to participate in walking training. And you had to have some walking function, or at least be able to walk at least 50 meters or 150 feet prior to your most recent stroke. Those individuals that did not meet this inclusion criteria are excluded from the analysis, but were still attempted to do the high intensity training as best as possible. So knowing that it didn't exclude them from getting the intervention, just the analysis. Beyond that, they were separated into usual care, transition, and high-intensity training just based on the time frames that they were admitted. So important to know, this is not a randomized trial. It's strictly looking at different time periods and when they were admitted to the facility. The one other thing that got people excluded from the analysis across all 3 of the phases where we decided that if patients had lengths of stay of less than a week and specifically discharged home, that meant that they weren't appropriate candidates for inpatient rehab. If the individuals had lengths of stay less than a week and say returned to acute care, those individuals' data were still included. So it had to be both the short length of stay and specifically discharging home. The one other subset of individuals that were excluded from the study were those in the usual care phase prior to starting the quality improvement project. So when this project first started, it was a research project, and we had to consent everyone whose data we wanted to use in this study, even in the usual care phase. And especially when you're talking about individuals that are this physically impaired, there are frequently some of those other comorbid stroke things going on, like cognitive deficits, say, is a major example, where consenting people is not an easy thing, and requires family to be available and visiting at a time that overlaps with the workday where research staff can go in and talk to them, and et cetera, et cetera. So there were individuals that we missed because we didn't have the capacity to consent them. The leadership at RHI decided that as a part of a quality improvement project, they wanted everyone to participate in this. They wanted everyone to wear the stepwatches. So we did that at their request. And then when the project was all done, we asked for IRB approval to use that information, which was granted. So that's where all this data ends up coming with, and how we ultimately end up with 131 individuals in usual care, 317 in the transition phase, and 208 in the high intensity gait training phase. So in terms of questions guiding our analysis, we first wanted to understand whether the patients were similar in usual care and high intensity gait training. So before we look at whether or not outcomes could be potentially different, were they all similar when they started? If they were similar when they started, were we successful at implementing the high intensity gait training? And then finally, if we did all that, did the high intensity gait training make a difference for patient outcomes? Because that's where it ultimately is, right? So if we show that we were able to change practice in terms of getting patients to practice walking more, work harder, but it doesn't ultimately make a difference for the patients, then that practice change really needs to be called into question about whether or not it needs to stay around. But again, the underlying assumption with that is that it's being done with fidelity. So there's always the chance that if you don't change your practice enough to do it with fidelity, it might be not that the intervention doesn't work, just that you didn't do the intervention sufficiently. Okay, so in terms of looking at the demographics for the three different groups, there were no differences in any of the demographic variables listed here across the three groups. The one other thing to add, and the data here are only from the high intensity training phase, was that these individuals had a lot of other things going on other than just the physical deficits affecting their gross motor function that we'll touch on the next page. So what I did here was I searched through the PT documentation for some of the keywords related to each of these different kind of comorbid stroke impairments. So in the 208 individuals in the HIT phase, in 62 of those individuals, or 32% of that population, there was some sort of documentation regarding aphasia as limiting the patient. 28% had documentation of apraxia, 88% had cognitive deficits documented, and 21% had controversive pushing documented. All right, in terms of the actual gross kind of functioning things that we think about as therapists, no differences between the three groups except for two things. One, Berg balance scale was significantly higher in usual care when compared to the other two phases. This is probably a function of two things. One, I mentioned that in usual care, we were consenting individuals for at least part of it. And it's harder to consent individuals generally when they're more impaired. They have a more severe stroke, and it's just logistically harder to consent people. So I think we missed some of those people. And the other thing I mentioned early on was that we had a difficult time getting the clinicians to collect outcomes on these really impaired people. So I don't know for sure whether or not outcomes were, or at least Berg in particular, was different at the start. My hunch would be that it's not, but it is based on the individuals that are actually included in this analysis. The other thing that's different between groups was the length of stay. So it's 2 days longer in the high intensity training phase. Whether or not this comes back to the balance, and people being more impaired and having longer lengths of stay when they're more impaired, I don't know. But knowing that there is a longer length of stay in the HIT phase. So these are the two things that are different. When we evaluate the amount of change in outcomes for the different things that we're interested in, we're going to statistically account for these two things. So we're going to account for the individual's Berg score, we're going to account for their length of stay, and then we're actually also going to account for the admit measure for that particular their item. But just knowing that these two things are different and they are accounted for in the analysis. All right, so we're going to say the patients were approximately similar between the different phases, enough that we're going to kind of keep moving down our list of questions. So in terms of what was actually done during the therapy sessions, in terms of the amount of walking practice and the prioritization of walking practice, what you see here is that with only the exception of steps per day, where transition and usual care were not different from each other, in all other instances, the high-intensity gait training phase was significantly greater than the transition phase, which in turn was significantly different than the usual care phase. So meaning that usual care was different than the transition phase in terms of the emphasis on practicing walking. And then the transition phase was meaningfully different from the high-intensity training. So even more prioritization and amount of practice of walking in the HIT phase. When we focus on that single metric we were interested in of trying to prioritize walking in 80% of sessions, we got to 78%. As you may recall, that was continuing to go up. If not for the pandemic shutting us down, I do think we would have gotten to there. But again, that was just an educated guess on what we might be able to do. So that 80% number, not a written in stone threshold, but we're going to give that a yellow check mark as well. When we look at the intensity of the sessions, similar to what was observed above, with the exception of peak heart rate, the transition phase was significantly greater than usual care, and then the high intensity training was significantly greater than the transition phase. So again, practice changes related to intensity for usual care to transition, and then additional practice changes from the transition to the high intensity training. So we're also going to give a yellow one there because we have the practice changes, but we really have no idea what's feasible for achieving for the cardiovascular intensity in these patients. All right. If we did this, did we make a difference for patient outcome? So we have 2 yellow check marks now, but we're optimistic enough that we may have done it, that we feel like it's appropriate to evaluate outcomes. So as I mentioned, accounting for Berg scores, length of stay, and that particular measure. So for the 10-meter walk, accounting for baseline 10-meter walk. For both the 10-meter walk and the 6-minute walk, the high-intensity training group significantly greater than the transition or usual care phase, with transition and usual care not different from each other. P-value of 0.07 for the level of assist for the 6-minute walk, which is going to be really similar for the 10-meter walk, which is why it's not shown, but not statistically significant between groups. Similar things for our other outcomes. Berg, not different between groups, but the FIM bed to chair and toilet transfers, significantly different, favoring high-intensity training compared to either transition or usual care. And then similarly for the stairs, same thing, high-intensity training better than either transition or usual care. No differences between groups for the FIM walk. So you have this consistent thing where high-intensity training is significantly greater than the transition or usual care, and those latter two not different from each other. The important thing here, aside from, I guess 2 important things here. One, with the walking outcomes, we're similar to what we talked about with the previous projects, we're prioritizing walking practice. So you would really hope that doing more walking would get you better at walking. And that in itself is great and important because of all the things that improve walking function are associated with. The related piece would be there are those other aspects of functional mobility that patients, also need to be able to do. Are we, because we're kind of manipulating that pie to spend more time doing walking and therefore less time doing these other things, are we getting these greater gains in walking at cost to these other aspects of functional mobility? And these data would suggest no. So balance changes were the same. And then surprisingly, even though you're probably practicing less, you're getting better gains at a few different kinds of transfers. So more walking practice somehow gets you better gains at transfers. The other piece globally that I think is really remarkable about these data are when we looked at the what was actually being done in the therapy sessions with the prioritization of walking and the cardiovascular intensity metrics, they were different between each of the three phases. So usual care, different than transition, which was then different from the high intensity training. That's not what we see here for outcomes. There is not any differences between usual care and the transition phase. So even though you had statistically meaningful changes in what was happening during the therapy sessions between usual care and transition, it wasn't enough to make a difference for patient outcomes. So moving the needle a little bit didn't do enough to change what the patients ultimately got. Okay, the last, or getting to the last data to show from here are those dose-response relationships. So again, looking at how much practice to how much better they get at their walking outcomes. A lot of dots here because there are a lot of individuals included in this study. But you have these dotted lines here indicating the regression lines for the two groups. And what you see is that they are very similar to each other. So it's not that the relationship between the amount of walking practice and gains in walking have changed with the two phases. You're just shifting more to the left. You're getting more practice when you focus on walking, and that's why it's contributing to getting greater gains in walking. So it's not that there's something meaningfully different other than you're just allocating more time to getting better at walking. All right, so adverse events. These are important, right, because you're weighing the pros and cons when selecting an intervention. There are two different analyses that are done on here. One is looking at whether the incidence of adverse events is different between groups, and the other one is looking at the odds ratio, or the odds of having an adverse event when compared to usual care. So they're similar but different. In the example, they become different really when you have a single person having multiple events. So the easiest one to talk about is falls. So in the transition phase, there was one individual that fell, I believe, 12 times. Those 12 falls would be counted as 12 separate falls when comparing the incidence of adverse events. But when you're looking at the odds ratio, that's just one person that experienced a fall. So they're similar, but they're a little bit different. And really, they're only going to be different as you get more and more of these individuals that have multiple instances of the particular event. So we were interested in significant adverse events or SAEs. The three that we were focused on were death, new stroke, or rehospitalization for any reason. We looked at them both individually as well as kind of added up together. So across all three phases, there were no differences in the rates or the incidence or odds of having a significant adverse event when compared to usual care. Similarly, for falls, there was no difference in the incidence of falls between the three groups. However, when you look at just the odds ratio, there was a significant increase in the odds of experiencing a fall during the HIT phase compared to usual care. You know this because an odds ratio of 1 would be that it's exactly the same, and the lower end of the 95% confidence interval is at 1. So this is just barely statistically significant. The thing to know here is that it's also elevated here, The odds of having a fall or likelihood of having a fall very likely related to the patient's balance, which we know is significantly greater in usual care, and potentially contributed to this. We also know that the vast majority of falls happen in the patient's room, generally when they're waiting for nursing to do toileting. So yes, falls went up. Balance was definitely worse in these individuals. Whether or not that specifically contributed, we can't say for sure, but knowing that the odds of experiencing a fall were higher in the individuals in the high intensity training group. Okay, in summary, hopefully this data suggested that it is feasible to increase the amount and intensity of gait training during inpatient rehab in the United States for individuals post-stroke that are very impaired, specifically when you provide sustained KT efforts. So different than Norway, where they went straight from usual care to implementation, we had that 18-month period of really trying to work hard to get practice to change. So really appreciating that you can do this, but it takes a long time, or can take a long time to make it happen. When we worked to make this happen, we found that we got improved walking outcomes, and we talked kind of throughout about all of the benefits of being able to walk better in terms of, in particular, discharging home, as well as walking the primary goal of patients post-stroke. The somewhat surprising findings, but really ones that have been found before with first Oslo and then in some of the research studies, were that focusing on practicing walking at a high intensity actually not only wasn't detrimental to some of these other aspects of functional mobility that are important to these patients, but actually had positive effects, in particular on transfers. There was no change in significant adverse events, and we talked a little bit about the falls and whether or not that was a significant contributor. But in terms of the major adverse events, no differences between groups. And the final take-home piece here was really the fact that the transition phase had statistically significant changes in what was going on in the therapy session. However, these changes weren't sufficient to positively affect clinical outcomes. So you really have to meaningfully change your practice to get the gains and outcomes that we want for these patients. So although I gave this talk, there were a number of individuals that made this project go, specifically the Locomotor Recovery Lab and the different individuals associated with that, as well as all of the different therapists and leadership at RHI that actually made this project go. So in addition to them, I'd like to thank the funding sources that also helped make this project go, and hopefully you found this talk helpful.